This week on the podcast, I'm going to show you a lecture that I gave a few months ago at the Eisenhower Emergency Medicine Residency out in Palm Springs, California. Now, this was actually a really fun lecture and venue. I'd actually never been out there. You guys were so nice. Special shout out to the Eisenhower Emergency Medicine Residency Program, and specifically Matthew Whited, who invited me, and all the faculty that I was able to meet, all the administrative people. Everybody's super nice. I had a great time. And I'm finally getting around to actually editing and putting out this lecture that I really haven't put on the podcast in a while. It is a lecture on nerve blocks. Now, this is going to be a bit of an intro. I'm going to start off by just talking about some basic stuff about blocks, about how to approach the nerve, how to identify the nerve, what LAST is, local anesthetic systemic toxicity, what are some nuances about the equipment to use, and then I get into some forearm blocks, the tibial block at the ankle, aka the posterior tibial block. I do the erector spinae block and the fascia iliaca block. Now, this is an hour-long talk. I decided to break it down into two different segments. I'm going to do part one now and a part two in a week. And without further ado, here's the video. So we're going to talk about basics, proper technique, indications, and then talk about some complications, because we have to know what will our intervention, like how can it harm patients. These are all kind of like gnarly injuries, right? These are all injuries that I've seen. These are all my pictures. And these are all patients that I've treated with nerve blocks, and they didn't need sedation. I was able to fix the problem just with nerve blocks. So you can imagine that it's a very important and easy and good thing to do. There are multiple different types of nerve blocks that you can, or local anesthetics that you can use. What do you guys use here? Do you guys use bupivacaine, ropivacaine, ropivacaine? That one's probably a bit better than bupivacaine. It's less cardiotoxic, and I don't really understand how it works, but in the literature, it says that it has more affinity for sensory neurons than motor neurons. So it's probably better all around. Now, what about the max dose? You guys know the max dose of those? For all of them. We have to know this. We can't give people LAST.
3 mg per kilo.
For which one? That's good. And then all of them are that's good. 10 points for you, for your house. So these are all of them, right? There's all and we have to know these. And the number actually is less in elderly patients. You actually want to decrease that by about 75% or so for patients with heart failure or elderly patients, because they're more susceptible to it. But these are the general guidelines. I try not to remember things I don't have to, and there is a great app that's free called MD Calc. You can set it as your favorite, which is what I do. And so this is basically what I do every time that I'm going to do a large volume block, is I just put the kilograms in MD Calc and then say what concentration and say what I'm going to give, and it will tell you what is the maximum dose you can give. If you have a multi-trauma patient, be a little bit careful with the amount that you give. Give less than the maximum dose, because there might be other parts, like they might have lacerations that need repaired in other places that also need local anesthetic. So these numbers, this is over 24 hours. So just keep that in mind, where if you have one injury, great, but if you're gonna have to give more, make sure you keep that in mind when you're giving that initial dose. Now, this is the big complication that we worry about. Has anybody experienced this in a patient? Yeah, right? Well, it's because most of the data for LAST is actually from non-ultrasound data where they were putting catheters in, meaning there was a continuous drip. So they were like continually dripping lidocaine into like an artery probably, right? Because it was when they did landmark-based approach to nerve blocks before ultrasound. But it does exist. We gotta be careful with it. I actually, I had an early lidocaine toxicity, not LAST, when I was a resident, because I wanted to have a good ultrasound clip of an ultrasound-guided intubation, because I think they're actually like helpful. And so I had some nurse anesthetist friends where I went to residency, and they snuck me into the OR, and they were gonna like intubate me awake. And so I kept doing the lidocaine gel. I did so much of it, and I still I couldn't do it. Like I couldn't even tolerate the blade, let alone the tube itself. And it was like
5 nurse anesthetists in the room, so I was safe, don't worry. But I couldn't get it done. And then on shift, because I was like going on shift, I was like lightheaded and like pre-syncable the entire shift, which is an early sign of lidocaine toxicity, so, you know. So it happens, but they don't always progress to last. Now, as far as equipment that you need, this is our probe, right? We need the linear transducer the vast majority of the time for nerve blocks. If you're doing a ping block on someone with a higher BMI, or really any block, you might need to reach for that curvilinear transducer. And in fact, unless they're like very, very low BMI, it's recommended to use the curvilinear block for those because of the curved nature of it being a little bit easier because your angle is acute, and generally it's still pretty deep. It's like probably more than 5 centimeters most of the time, which 5 centimeters is about the maximum depth that a linear transducer can see well, kind of on average. So curvilinear otherwise. Now, with regards to sterile sheaths, this is something that is kind of debatable, but I'll tell you what I do. If I am doing a peripheral block, so forearm or calf down, I generally am just using a Tegaderm, a sterile adhesive dressing, and sterile gel. I always use sterile gel. But if I'm doing anything more proximal to the knees or elbows, I'm just going to put a sterile sheath. It doesn't take that much work, and if it decreases the incidence of something major happening, even by like 1%, for me it's not that big of a deal. Plus the probe itself is cleaner, it's easier to clean up and all that stuff. The issue with not using the Tegaderm with everything is when you look at the data technically, there are very small virions that on average are smaller than the pore size of the Tegaderm. So there is a theoretical risk that hepatitis B is one of them, that hepatitis B might be transmitted if you had it on the probe and didn't clean it and then just put a Tegaderm on. It could be transmitted, especially if you're central or if you're near a mucous membrane, but it's never been reported. It's literally never been reported. And we're cleaning the transducer before we put the Tegaderm on. I mean, really what I'm doing for the Tegaderm is I'm adding a slight increase protection to the patient, but it helps me with cleanup because there's often a little bit of blood on there and there's gel, and if I just do it with the Tegaderm, then take the Tegaderm off, the probe is clean. I'll still clean it afterwards. Do you guys have gray tops or purple tops, the wipes?
We have like Sono, like pack.
Yeah?
And the purple tops.
Okay. Great. Or the gray top, is it kind of like the ultrasound one?
The ultrasound ones are the
Like there's Sono wipes,
wipes,
yeah.
Ultrasound wipes.
I wonder if they're different from the gray wipes. Because for us, like it's the gray wipes are the ones that they recommend using for machines, but honestly the purple wipes would work fine. If you talk to most ultrasound manufacturers, they'll recommend not using the purple wipes because they're a little more corrosive, but I've literally never seen a probe break because it was being cleaned by the purple wipes. And I say this respectfully, I've just worked in residencies for a decade. You guys are gonna break the probe before the purple wipe will break the probe. You know? So if that's all you have, it's probably okay. If you leave a purple wipe on the transducer, meaning like it stays wet for 3 minutes, that's actually considered 2 minutes, for the purple wipes, it's stronger. That's intermediate level disinfection, which is one layer below high level disinfection, which is when you send it somewhere to be clean. So if you're doing it 2 minutes with a purple wipe, 3 minutes with the gray top wipe, it is way clean. Like there's an argument, even like especially for IVs, that you don't need a Tegaderm, actually. I still use it. But just know that if you clean it right with the wipes, they are clean enough to be able to do many of your procedures without that. Do you guys have nerve block needles? Great, they're amazing. If you happen to not have a nerve block needle, I would use a spinal needle with some IV extension tubing. Because if you can hold the needle, you're so much more dexterous with how you can move things around than if you have that giant syringe like a foot away from the patient. You're gonna be wobbly, you're not gonna be as exact with your pokes. The other thing too is that imagine that this is the needle, like this is the end of the needle here. I grab it at like right here, like almost at the stabby part, and I'll poke through the skin with that, and then I'll feed the needle in this way. So I don't hold it all the way back because I don't have as much control. I hold it like a pencil, and then I kind of feed it in just so I can have more control. And if you have those blunt tip needles, which you should be using, by the way, if you have the blunt tip needles, sometimes it's a little hard to get through the skin, and you're gonna like tent the skin and tent the skin and tent the skin, and then finally it'll pop, and then the skin retracts and you're 5 centimeters in the patient already, right? That's another reason why I hold it here, because my fingers are a stop. So once I get it in, it's not gonna go past like where my fingers are at. That's another reason why. I will use the cutting needle sometimes for forearm blocks because they're smaller than the nerve block needles. If I have somebody that's nervous or I'm doing a forearm block, I'll use a 25 or 27 or 28 gauge cutting needle for forearm stuff. But if I'm doing anything near a blood vessel, anything central, I'm using the non-cutting needles. They're a lot safer. You're less likely to cause injury to surrounding structures with those non-cutting needles. Excuse me, I'd recommend that for the vast majority of the cases that you do. You can do this thing, which I have a hard time with this. Do you do this, Matt? I have a hard time with like the thing, and you talk to nerve block experts, like the people who taught me, and what they will say is they want or they recommend the anesthetic here, and then just normal saline to hydrodissect as you go in with the needle, and then switch over to the lidocaine when you know you're in the right spot. But my thought is like, then you're not anesthetizing as you go in, which is what I would like to do. And if I waste 1 to 2 cc's going in, like that's not gonna be clinically significant. And it's less complicated than doing the stopcock, kind of the 3-way stopcock technique. And so I don't use it, but know that you can, and certain places, that's their guidelines. I do whatever the guidelines are at your institution, but you don't necessarily need to do this. I don't. It's more complicated. But it is a 2-person technique, right? You can't hold the probe, hold the needle, and hold the syringe at the same time. Always check with whatever institution you're in, but where I'm at, I grab a nurse to help push the anesthetic because they can push drugs, right? I'm holding the needle, and I will just say, give me a very small squirt, a little bit more, a little less, aspirate. So I'm kind of just telling the other provider what to do. You don't necessarily need 2 physicians to do that. You don't need an MD degree or a DO degree to like aspirate and push an injection with another provider there. From my opinion, local guidelines, right? Always follow those. Now, we're not targeting a nerve. This is probably a review for a lot of you. We're not targeting a nerve. We're targeting the fascial plane in which the nerve lies. This is a PEX 2 block that I did a while ago for chest pain. And we can see there, what we want to see is we want to see right next to that hyperechoic fascial plane, we want to see the anesthetic unzip the 2 muscles, basically. We want to see it spread along that fascial plane. If we don't see that nice unzipping, we are in the muscle belly or in the nerve. We should stop injecting, reposition, and then inject again. Lots of nerves in the body, right? This is one of those like exhibitions that they do of human bodies. And I actually really like anatomy, and I know anatomy so much better now than I ever did, even as a med student. Like I know anatomy better now compared to when I was like just done with anatomy as my first year, which is when many of us are the smartest. I feel it's the end of our second year of med school is when we're like the smartest. But I know anatomy so much better now because I have to know where everything is to do all the nerve blocks that I do. To know what nerve is the right nerve, you can memorize stuff, but there's also an app that my colleague where I work, Mike Macias, he's one of the ones that developed this app, and you basically just say where the injury is, and then it'll tell you what blocks work, right? So another app that you can use to facilitate your practice. This is something that people get confused about a lot. It's just called the nerve block app, I think. People get confused about this a lot. It's nerve versus tendons. And I've seen, like, I do QA. I'm the QA person at our shop. And I've seen people anesthetize what I know is the flexor carpi ulnaris tendon down here. I know they're anesthetizing that and not the deeper ulnar nerve right here. There's a couple of ways that you can tell the difference between a tendon and a nerve. One of them is a concept called anisotropy. So you see how and what I'm doing is I'm fanning the transducer. The tendon almost completely goes away. The nerve gets a little darker. The nerve's the bottom left one, but it is, it's still there. Another thing that you can do is you can move your transducer up the arm, and if you move it up the arm, you can see that it will continue on as a structure, or it'll disappear. The tendon will disappear as a structure, whereas the nerve will continue on. Here's the median nerve, just to show you, and then we have the palmaris longus tendon. That's that kind of big one right there in the middle. And you can see as I move proximally, you can see that the tendon basically turns into the muscle, it disappears, whereas the nerve stays persistent. So that's another way to tell the difference between the tendons and the nerves. There are 2 like 0.5 techniques that you can use. It's the in plane, the out of plane, and then what I call the way out of plane. I call it the whoop technique, where you basically are almost at like a 2-degree angle relative to the transducer. You don't get great needle visualization, but sometimes you just don't have room to be able to come at it at a 45-degree angle in the short axis, which is what you need to do to see the tip of the needle well. So I kind of just will go like this, and it's basically identify the target, and there's a specific nerve block that I use this for mostly. It's a specific target, I center it, and then I know if I go straight in, and I'm hydrodissecting as I go in, if I go straight in, I should get to the area that I want to get to. Now in plane, this is the best way to do it. I think that yellow circle is a dot. You inject, and this is what you are trying to see. You want to see that spread in that fascial plane. Do you guys like that animation? It took me a long time to make that, actually. I'm like, it was a lot of different steps. And this is what it looks like here. Right there, this is an SCP block. This is the sternocleidomastoid up here. So this is long axis. This is probably the best way to do the vast majority of our nerve blocks. There's an issue with long axis. It's really hard to keep that needle perfectly visualized because everything has to be 100% lined up perfectly. And you can see here, like, it looks really good, right? It looks really bright. I have really good reverberation artifact. I can see it, but I'm going to move my transducer just a little bit to the right and just a little bit to the left, and I completely lose sight of it. So just know that that is one of the things, is you have to constantly redirect your transducer, rotate it to make sure that you're staying in line with, at minimum, the distal end of that nerve block needle. Now out of plane, we try to do it at a 45-degree angle because that will give us the brightest reflection back. So actually, and I do this for IVs as well, I'll tilt the tail away from me towards the patient, and that makes the needle tip as I'm going into the short axis be so much easier to see because I'm much more at a perpendicular angle, which gives me the brightest reflection. And you want to get right next to that transducer, and you want to put that anesthetic in there. Now this is tibial nerve, which sometimes we call this the posterior tibial nerve, but anesthesiologists make fun of us and laugh when we do that because they just say, like, it's just a tibial nerve, like, don't worry about it. But here's a tibial nerve right here. We're doing it in the short axis. You can see here, I can see that needle tip, and I can see that hydrodissection from that hyperechoic needle tip surrounding that tibial nerve right there.
I'm going to take a brief pause here and remind you of our courses.coreultrasound.com website. Now on this course, we have a fundamentals course. We also have all the conferences that I've run in the past probably 5 years, and we're about to add another one. Would probably be out just after or right at the same time that you're getting this, the Sound and Surf course that we just finished in November here in San Diego. I recorded all the lectures, and they're all going to be available on the courses.coreultrasound.com website. And we have a very unique question bank that doesn't really exist outside of core ultrasound, where we respect your medical knowledge. We know that you are a clinician, but that you might not have a whole lot of ultrasound training. So we just ask you, is this a pneumothorax or not? We definitely support you more than just, is it this or is it not? It's actually multiple choice questions. We have video explanations of why it's that certain thing and not this other thing. So with this, we can actually bring you into a situation where you're much more comfortable looking at ultrasound clips and being able to confidently identify if there's pathology or not. That's on our question bank part of our courses page. Check it out. And now back to the video.
Now these are the blocks that we are going to go for here or discuss. These, I'm going to kind of breeze through this one because I think most of us know or are familiar with these nerve distributions. The ulnar block is the most common one that I do because it's the most likely to have a boxer's fracture, which in Temecula we have a lot of young angry men and they punch a lot of stuff. So I actually do this frequently, even if I don't need to reduce it, just because it decreases pain in that entire area. It does the inside of the hand and it does that entire outside of that hand. Can anybody identify this injury? What is that? It's a left hand. Most people are right-handed. We would see it so much in Kentucky. It is forgot that the gun was loaded and cleaning it. That happens so much. Like this was an injury I probably saw it once a month at minimum, where they took the magazine out, but they forgot to take the one out of the chamber, because you have to have one in the chamber, right? And then they'd accidentally shoot themselves. But these work very well with that ulnar block. Now, as far as location, I don't do these almost ever. Actually, I never do these at the wrist. And the reason why is because if you really want a dense block, you don't want to anesthetize it after the superficial branch is already split. And everybody's anatomy is variable, right? Sometimes it's right at the wrist where it's split. Sometimes it's like 2 to 3 centimeters. Sometimes it's 5 centimeters away from the wrist where it will actually split. And so I do them mid-forearm and above. The other reason is that the artery is right next to the nerve, and in fact it's a landmark if you happen to be doing this not ultrasound-guided, and please don't. But as you move up the arm, the artery splits off away from that nerve, making it a much more safe target, because it's just a nerve in between two muscle bellies. There's nothing else there. So here is how we identify that. We have that transducer over here. On the ulnar side, I press a little bit to look for that pulsation of that ulnar artery, and then I'm going to identify my artery and my nerve, and then I'm going to bring that transducer proximally until I see that nerve split off from that artery, and this is my left arm, right about here. You see where like the artery dives away? That's where I do the block. Lastly, the reason why I don't do them at the wrist is that, do you remember the homunculus? Like I said, that ridiculous, like nightmare-looking person. Remember the hands are huge on that thing? The sensory innervation from your wrist down is a lot more than the sensory innervation of your forearm. So it also hurts less. So there's 3 reasons why I do it on the proximal forearm. This is where I approach it. Here's an example, and I put this here. The patient had a dislocation fracture. Sometimes it's actually all the way over here, and so what I do is I'll put towels here and then have the patient rest their arm here, and then I'll come with their arm flexed, actually like hyperflexed, to be able to reach the ulnar nerve. And there you can see my hydrodissection going on the top of that nerve there. Any questions on the ulnar block? Yes?
Do you use ropivacaine for this as well, or just do lidocaine?
It depends. If they have, we'll say a lower ability to deal with stressful events, I might use a combination, because the ropivacaine takes a little bit more time than the lidocaine with epi to kick in. If I'm doing it for a reduction, and I know after reduction they'll be fine, I'll just do lidocaine with epi. So most of the time when I'm doing this block for a boxer's fracture, it's generally just lidocaine with epi. And it lasts about 4-ish hours on average, which is enough for me. Yeah? Lidocaine with epi is so much easier for us to get too. Like we don't have ropivacaine, we have bupivacaine, and it takes like an hour to get it from the pharmacy, whereas like we have lidocaine in our Pyxis in the ER. So that's another reason why I use that. Radial nerve block, this is like my least common one that I do, because it's least likely to be isolated to just this area right here, this sensory innervation. But I have done it a couple of times, mostly for road rash on motorcycle wrecks. That's the same thing as the ulnar nerve. We want to do it more proximally for the same reasons that I mentioned before. And here's how we identify it. Very similar. We identify that radial artery. And it's the smallest nerve, and so at the wrist it's actually really hard to see. But as you move more proximally, it will get bigger. And you'll be able to see it a little bit easier, because all of the little branches are like going off of it as it moves away from your brachial plexus. And so the more proximal you get, more of those branches have like kind of come back to the main nerve. And so it gets bigger and easier to see. It's going to be lateral to that radial artery, and then you can track it up until it breaks off, and then that's where I would do the block. Right there. So here is an example. This one, we don't have a great like visualization of that nerve, and this one is done at the wrist, which again I don't always recommend, but you can see here how once I start doing hydrodissection, I can actually see the nerve, whereas I couldn't really see it before. It was just like in the fascia, and I knew it was there. But once you actually put anesthetic in there, it often will kind of separate it out for you and help you visualize it a little bit easier. Any questions on the radial block? Medium block's probably the second most common forearm block that I do. Can anybody name this? I'll give you 25 points if you can tell me what type of abscess this is. It's got a specific name. It's a button collar abscess. And it makes an abscess that goes clear through, and it generally needs surgery actually to fix because it's usually deep to the muscles. It's kind of rare, but they'll come in with their fingers like this. They can't bend the fingers and they have an obvious abscess there. And you have trauma to the thenar eminence. It's helpful for that as well. Now for this, you can kind of do it anywhere, but for the same branch off discussion as with the other nerves, I generally do it right at the mid-forearm. There's no other important structures really in that area at the mid-forearm than the median nerve. That's the only thing, so you don't really need to avoid anything per se. I place a transducer on the forearm and I look for the superficial flexor and the deep flexor. I'll move my transducer up and down until I see a hyperechoic honeycomb structure that stays persistent in between the two. You guys see it? It's a good median nerve right there. Here is an example of performing the block. You can do this in plane. I generally do it out of plane because the distance between the AP distance basically is less than the lateral to medial orientation. So you're going through less tissues. And when I was a fellow, now I'll just say it's a flex. When I was a fellow, I actually asked my ultrasound director to do the nerve blocks on me so I could understand what they felt like. And so this block, the median block, was the only one that hurt because he went through one of my tendons inadvertently. And so because of that, because we have a lot of strong tendons laterally, that's another reason why if I'm gonna go laterally, I actually bring my transducer. I'm gonna put my mic down for 1 second. Hopefully you can still hear me, I'll talk loud. So what I do is, let's say that I'm coming at it this way, let's say, right? I'll have the transducer here. I'll know my target is there, but I'll bring the transducer out here to catch the needle as it enters the skin, and then bring it this way with the needle tip until I'm at the spot, and then leave the transducer there. Just because you want to know and try really hard not to go through those forearm tendons because they hurt. I usually am doing this in a short axis to avoid those things that I mentioned. And here you can see in short axis that nerve being infiltrated, the nerve itself is not being infiltrated, the fascial plane is being infiltrated to anesthetize that median nerve. Any questions on the median nerve? Great. Now, tibial block, the ankle one. Now, I don't know if you guys know this, but the calcaneus is basically completely innervated by the posterior tibial nerve, which if you block that, it fixes the pain for most calcaneal fractures. Put that in your armamentarium. The one kind of caveat is that some orthopedic doctors have a hard time with the concept that has never really been proven, by the way. The concept that if you do a nerve block, it'll mask ischemic pain from compartment syndrome. And it's never actually been reported. What has been reported is patients with nerve blocks, with nerve block catheters who have breakthrough pain. And then they identify compartment syndrome because the pain fibers allegedly, and this is something that Arun Nagdev has taught me, allegedly the pain fibers from ischemia are different than the pain fibers for like pain. And so it's a different mechanism, and patients can feel through the nerve block that you've done if they happen to have ischemic pain. But know that a calcaneus fracture, if it's closed, it is one of the slightly higher risk ones for compartment syndrome. So I would talk with the orthopedic colleague before I would do this block for that indication. We had a lot of barefoot walkers in Kentucky, a lot of children, and I don't know has anybody tried to anesthetize the plantar surface of the foot? It's never worked for me. Like I've never been able to do local infiltration, and it worked to remove a foreign body from the foot. You do a posterior tibial block, and you're away from the site that's already painful, already irritated, and it completely blocks the entire bottom of the foot, and you can dig around there with as much as you want to, and the patients don't have any pain there. If I'm doing this block, I tend to use a little bit more of the long-acting stuff because the digging around often causes problems, you know? But yeah, this is a quite useful block. Location here, we're gonna externally rotate our foot. We're gonna place a transducer just posterior to the medial malleolus and just cephalad to the medial malleolus. And this is our tibial nerve, and this is gonna be our approach for that needle. And this is an example of a live block. This is it was actually kind of interesting to drive without being able to feel the bottom of my foot. It's a fun experience. It's fine. I could feel the top of my foot. So I had proprioception, but it was just weird. And so this is basically how your approach should be. And this needle, I don't know if you know that, but that needle is a 27 gauge. And the actual injection of it like didn't really hurt at all. Like it was very not that painful. And actually like we'll tell patients when I'm talking to them risks and benefits, like here's the risks and benefits of sedation, here's the risks and benefits of hematoma block, and here's the risk and benefit for a nerve block. I always tell them that because it's true, like I'm a bit of a wimp and I could tolerate all of these blocks. And if I can, I feel like most people probably would be able to. Because if you're using a 27 gauge cutting needle, like it really doesn't hurt that bad. If you can, do it in the long axis, just because you have better needle visualization. The issue is that if you have somebody that is low BMI, you often can't get around the Achilles tendon to do it in the long axis. Because if you come anterior to posterior, you are going to very likely run into the tibial artery, and you don't want to like, there's not a good way to get around and scoop behind the tibial artery coming from anterior, so you kind of have to do it from behind. If someone's higher BMI, those are perfect to do them in the long axis because they have a lot more soft tissue, and then you can avoid the Achilles and be able to approach that posterior aspect of the nerve.
That's it for this video. Don't forget to check out the Ultrasound Leadership Academy, the courses.coreultrasound.com website, and any of our free stuff we have online on the YouTube, the podcast, or the website. Hope to hear from you soon, and happy scanning.